you
All
want
right.
to try one of these?
Dr. Freeman, if you just want to give me the go-ahead whenever you are ready, we will get started.
Okay, I'm fine. Let's go ahead and get started.
All right, perfect. So welcome, everyone. We appreciate you taking the time today to join us. So we have Dr. Alison Freeman, and she is an assistant professor at the Division of Gastroenterology and Hepatology at the University of Colorado. And she will be discussing today bowel prep and what's available and things that we can do to make our patients' experience as successful as possible. Please make sure that you are muted just while we are in the discussion, and I welcome you to type any questions you have in the chat. And then we'll have a more open Q&A at the end of the session. So Alison, whenever you are ready, I welcome you to start.
Okay, well, thank you, Amy. I appreciate it. You guys will not be seeing my picture today. My setup here is on my desktop. It does not have my video camera. It's only on my laptop, so I apologize. I'm just going to be the voice and the ether for you today. As Amy said, I'm going to talk today about how to help patients through the prep part of prepping for a colonoscopy, and kind of why we do things the way that we do it, tips and tricks for the patient, and kind of some pearls to kind of help ease that process for the patient, because it is a pretty big deal to everybody involved. If you have any questions, though, as we go along, please feel free to type them into the group chat thing. If I see anything pop up that looks like we should address it now, I'm happy to do that. Otherwise, as Amy said, we'll do questions and answers at the end as well. So today, sorry. Come on. We first have to figure out how to advance this. There we go. Okay. So today what we're going to be talking about is first what makes a good prep, both for the clinician as well as the patient. We're going to talk about dietary considerations leading up to the prep, and then to have a discussion about the different bowel preps that are currently available. We'll talk about the process and kind of what does that entail, the pros and cons for the different options that are available, specific contraindications to certain groups of patients, and then kind of how to help the GI doctors come up with the appropriate strategy. Are there things that we should know about the patient that is important to know up front so that we can help pick the right prep for the patient? We'll also be talking about kind of from the patient perspective, what's a normal response, what's not normal. We're going to talk about additional considerations and questions that the patients often have, and some tips and tricks to ease this process for the patients. So first, what makes for a good prep? Well, that depends really entirely on who you ask. There is the there is the physician perspective, the person performing the procedure, and then there's the patient perspective. The physicians, the main concerns for them are going to be, is it a safe prep for the patient, and does it work? Is it efficacious? Are they going to get the results that they need? They also are concerned about the patient satisfaction, but the patient concerns are quite different. They want to know, is it going to make them feel nauseous? Is it palatable? How much volume of stuff are they going to have to drink? What are the expected side effects? Is this something that they think they could reasonably accomplish? And with everybody, though, our overall goal is to try to find polyps so that we prevent those polyps from being able to turn into colon cancer. So that is the ultimate goal that we all need to be working towards from both the MD and from the patient perspective. So let's talk a little bit about what makes a good prep. And as I said, this varies depending on who you ask. So let's start with the physician. What do they value in terms of a good prep? Well, a good prep allows us to wash all of the debris out of the colon so that we don't miss anything. We can see those little small polyps. You can see in this graphic that when there's stool filling the colon, the little small polyp that kind of at the bottom of the colon in front of the camera is not visible when you put a lot of stool in there. So bad preps can hide polyps. What does this look like in real life? Well, we typically grade the polyps or grade the preps anywhere from excellent all the way down to poor or inadequate. And you can see the different representations of kind of how much stool is filling the colon. You can imagine that if on kind of in the fair, poor, and inadequate categories, that if there's a lot of stool in there, that's much more likely that we may miss something. Usually we're not going to miss something really big, something that's filling the entire lumen of the colon, which is typically a colon cancer, but we could easily miss small polyps and may prevent colon cancer down the road. This is just a picture of what polyps tend to look like in terms of sizes. So they can be very diminutive, as they are in the upper left picture, to quite a bit bigger and partially filling the lumen of the colon in the bottom left picture. However, there's also the patient that we that's also an important equation in all of this, and they're going to have concerns about things from a medical perspective. What did they have to do with their diet to prep for this? What can they do with their medications? What are they allowed to do? What are they not allowed to do with their medications? There's a lot of psychosocial aspects that come into play from the patient perspective, including just psychologically psyching themselves up to get this procedure done in the first place. They need to often take time off of work, and they may need to arrange someone to be their escort, because they're all going to need to have someone be able to drive them home from this procedure. And so sometimes that can be a big rate limiting factor for patients. And then the biggest worry that a lot of patients have is the purgative, the bowel prep itself. What exactly is that like, and what does that entail? When you look at the commercials or like kind of the ads for different bowel preps that are out there, they often have these really nice pictures of kind of, this is how you're going to take your prep. But this is more what the patient's perspective is on it, that it's something that they really dread having to do because it's going to cause a lot of discomfort and anxiety. So we're going to talk about ways that we can try to ease that process for the patient, kind of, and find something that will work well and how to ease that process along. So let's first start talking about diet and how we go about prepping in terms of diet. Now, I think one of the biggest important things for them to do, and probably one of the things that they do the least, is to avoid having foods that are high in fiber, high in a lot of seed content, nuts, popcorn, those kind of things. They should try to avoid those for 1 week ahead of time. And I can't tell you how many colonoscopies I do where it looks like there's pieces of onion still, because the skin of the main portion of the onion it goes through undigested, and that kind of fibrous content really can be difficult to clear, because it's not something that we can suction out of the colon and clear out. It's just something that kind of gets in our way. So avoiding that for 1 week prior is really important. However, most patients are not really thinking about their colonoscopy prep 1 week prior to their procedure, and so I find that a lot of patients actually don't do this. Now, we're never going to ask them to reschedule their procedure if they forget to do this. We're just going to have them kind of get back on track, but it is something that could be really helpful. The day prior to the procedure, for most patients, that is when we're going to start a clear liquid diet so that they can have the things that are shown in this picture. Anything that they can see through are things that they're allowed to have. Things that they can't see through, they should be avoiding. There are certain patients, though, that we may start this clear liquid diet more than just 1 day in advance, and often that's two days of clear liquid diets. And those are typically diabetic patients that have inherently slower gut motility, patients that are on narcotics because of the slow gut motility and the more difficult time that it is to clear things out, or patients that have had a failed prior prep, meaning they've had an inadequate prep and we haven't cleaned them out thoroughly. We'll put them on a 2-day prep as well. So in terms of what are they allowed to eat, as I mentioned, anything that they can see through is acceptable. And so the good options are things like Gatorade, Jell-O, broth, sodas, black coffee. Some patients ask me about beer. That technically is fine, although we discourage beer in general or alcohol in general because it can be dehydrating during this process. Things that they should try to avoid include milk, anything that has a pulp in it, so like orange juice or kind of juices that they can't see through. Chicken noodle soup is if they just have the broth, that's fine. If they try to eat all of the noodles and the chicken with it, then that's not okay. And believe it or not, I've had people ask me about burgers, and no, that is not a clear liquid. They cannot have that the day prior. The other thing that we generally recommend is that they try to avoid having anything with a red dye to it. And that's because sometimes the red dye can come through still pretty intact, and it can have the appearance of blood, and so it can make things a little bit more confusing. Not 100% important, but it's something, something that if they can avoid it, it's best. And then we're going to tell them that at midnight, the night before the procedure, they'd have to be in PO. So nothing except for the prep, or they can have most of their medications, they're allowed to have that with sips of water the morning up or the day up with their procedure. So let's talk a bit about what are the prep options that are available. The one that we still traditionally use, and it's been around for a long time, is something called a Go Lightly prep or a Colite prep. This is a PEG-based prep or a polyethylene glycol-based prep. This one, the Go Lightly and the Colite, those are 4 liters or 1 gallon of liquid that they have to drink down. But they're considered to be an isoosmolar prep, meaning when they drink this, their electrolytes, they're not going to have a shift in their fluid levels or their electrolytes. So it keeps things neutral from an electrolyte standpoint, and they won't get dehydrated on it, despite the fact that they're going to have a lot of diarrhea with it. Another option that is frequently used that's also a PEG-based option is something called a Miralax Gatorade prep, which is available with a combination of ingredients that are pictured here in the photo. This one, we will talk about the efficacy. Anecdotally, this one does not clean the colon adequately. We switched to this prep earlier this year here at the university for a short period of time. It just didn't work. There was just so much debris left in the colon that we ended up having to go back to the traditional prep. So in a real life scenario, I don't think that this is a very good option, since our main goal is to try to clean everything out of the colon. It leaves too much residual stuff on the walls that we need to then deal with. Although this one, I will say, is much preferred from a patient perspective because it doesn't have any flavor in the Miralax compared to the Go Lightly. Some other options that have become available are lower volume options. The one at the top is something called MovaPrep. It's actually been replaced with something new called, I think it's Plenview is the name for it. That one is about half the volume of PEG compared to the Go Lightly and the Colite. So it's a 2 liter instead of a 4 liter solution that they have to do. Suprep in the middle is a different type of, it has a different mechanism of action altogether, but it has a low volume compared to the others. You end up making up only 1 liter of solution to drink as compared to the 4 liters or the 2 liters with MovaPrep. They are, though, not supposed to just drink the prep itself. They have to also consume a really significant amount of additional liquids, like water, Gatorade, that kind of thing, in addition to that prep. So their volume is actually not significantly different compared to some of the other prep options. And then the last one on the bottom is the sodium picosulfate solution. This one's a pill-based solution. We don't use these don't work very well. And then another option, another pill-based option is something called OsmoPrep. This is, again, not something that we typically use. Some patients will have been exposed to it in the past and may ask about it, but it doesn't tend to work well in a real life scenario, so we tend not to use it here at the university. This is just a table view of the information some of the information that I said before. It kind of goes through all of these different prep options that we have in studies. How efficacious was this in terms of developing an adequate prep? And you can see that the variability, there's quite a bit of variability with these different options. In real life scenario, I don't think that all of these are purported as what their studies have said. I think that in general, Go Lightly and Colite tend to work the best, although you're going to have patients that just have a difficulty consuming all of it, but when it does all get consumed, it works extremely well. Miralax Gatorade, the adequacy levels don't appear to be all that bad, but in reality, they were pretty bad. That we only went on it for a very short period of time before all the GI doctors revolted, and we went back to the other stuff. And then the Suprep that's at the bottom, that's those two small bottles that they take. Those ones in studies have shown that that works really well. In my experience, I don't think it works as well as the Movaprep or the Go Lightly and Colite, but that's, again, more anecdotal than anything. You can see that the cost varies quite a bit for the patient. And a lot of this cost also depends on what their insurance decides to cover in terms of their copay, and if the insurance has a preferred prep that they like to use. In general, the disadvantages you can see listed. In general, the biggest cons with the PEG-based solutions, including the Go Lightly, the Colite, the Movaprep, the taste. I rarely come across a patient that says that it's not horrendous. Most people absolutely hate it, and it's got a lot of volume to it. So they really can make some patients just really miserable when they actually have to go through the process. The Miralax Gatorade prep, that one is not an FDA approved prep. It is much more palatable to the patients. There are some case reports of severe hyponatremia, including a death related and attributed to that prep. So it's not something to be taken trivially either. The asthma prep, we don't use that one. As I mentioned, this is a pill-based prep. It definitely should not be used in anyone with significant comorbidities, including renal disease, heart disease, or liver failure, as it can lead to volume depletion and electrolyte shifts. Anyone that's on an ACE inhibitor or an NSAID also should avoid this one. And there's a risk of acute phosphate nephropathy or kidney injury from this medication. The Suprep also, it works, it's a different mechanism of action using an oral sulfate solution, and this one should be avoided in patients with renal disease, heart disease, or liver failure, as it can also lead to volume depletion and significant electrolyte shifts. Should also avoid this one in anyone that takes chronic NSAIDs or ACE inhibitors. So what is the process? What do we actually tell the patients on how we do this? The process varies a bit depending on the prep. As you can imagine, the pill-based preps are going to be quite different than the liquid-based preps. I'm going to be focusing on the liquid-based prep since that's what we use here. And generally speaking, the way that we do this is that they're going to be asked to take all of the prep plus some additional laxatives and or simethicone prior to the procedure. And the method for doing this varies quite a bit. The traditional method that we used to use up until a few years ago, 5 or 6 years ago, was where they would drink all of the prep the night prior to their procedure, and then be NPO at midnight for their procedure and come in with no additional prep that day. What happens on that is that there's often a lot of residual sticky chyme or kind of like this kind of mucousy stuff stuck to the walls. And so what we have switched to, and now is kind of the way that everyone does it, is something called a split dosing method. We're going to talk about that more in the next slide. And then there's also a move to consider same day prep. So let's talk about those two options. The split dosing is now considered to be standard of care. And what we do with this one is to drink half of the solution the night before. So they generally start at somewhere between like 6 o'clock and 9 p.m. the night before. And then they get up really early, depending on when their procedure is, and take the second half of the solution the day of, the morning of. What this has been shown to do is that by splitting up the bowel prep, is that it improves the bowel prep cleanliness, which leads to better quality colonoscopy, less likely to miss polyps. And it also improves patient satisfaction. They say that there's a lot less bloating, less nausea, pain, and therefore it leads to a higher likelihood that they'll actually complete the entire prep instead of drinking only part of it. One of the things that you may appreciate is by looking at the timing of all of this, particularly with that morning dose one, we asked them to do that one 4 to 6 hours, start that second half 4 to 6 hours before their procedure is scheduled, which we start procedures at 7 a.m. here. So that means that these patients are sometimes waking up somewhere between 1 a.m. and 3 a.m. to start the second half of their prep. So you can imagine not a very easy night for the patients at all to do this. When patients are scheduled in the afternoon too, they're going to be asked to do their second half of their prep in the morning. And one of the things that has been investigated recently is to look at how could we improve preps for patients that are scheduled in the afternoon. Because in those patients, the split prep works, but it doesn't work as well as if we could just do it all in the same day. So we are doing some studies looking at drinking all of the bowel prep the day of, and the morning of, if they're scheduled for the afternoon. So that may be something that's coming down the pipeline down the road. Right now, we're trialing this, and we're not really doing that on a wide scale basis, but that may be something that you start hearing about. So how can we optimize the prep? And as I said, this is kind of a balance between, we want to make sure this is an efficacious process, but also not too onerous for the patient. So the first step that we need to do is to pick a safe prep. We need to be looking for significant cardiorenal comorbidities, liver disease. We need to be looking at their medications. One thing that doesn't really involve the prep itself, but if these patients are on blood thinner medicines, that we're going to be asking them to hold those ahead of the procedure. And then we want to certainly know about if patients are on chronic NSAIDs, chronic opiates, meds like that could potentially have an impact in what we choose in terms of our bowel prep choice. We want to pick the best prep for the patient. We want to pick one that they will be able to do. And so that is usually weighing both the cost and how much it will cost the patient to the tolerability. Some patients just, are very upfront and say, there's no way I can drink all of that 4 liters of volume. It's just too much. I won't be able to do it. Similarly, though, I've had people that with that low volume one, that Suprep, that has the two little bottles that are 1 liter total, they've told me that stuff tastes awful, and that when they've had multiple different options, and that one's by far the worst in terms of taste, so they would prefer not to do that one by any means. So it varies by the patient. We also need to look for potential intolerances, especially people that have already gone through this process. Was nausea such a big deal to them? Do we need to try to pre-medicate them with antiemetics? And that is something that we sometimes have to do for some of these patients. And something that we would want to, if you knew that this was an issue, trying to kind of reach out to the people in GI so that they can make sure all those things are appropriately ordered. The most important thing is that the patients need to adhere to the instructions, meaning follow the dietary instructions, drinking all the prep when they're told to drink it. And so spending a lot of time making sure that all of that information is getting correctly communicated to the patient is going to be very important. And then we talked about split dosing, doing half of it the night before and half of it the morning of. So what should we tell the patients in terms of what to expect? What is the process like for them? Most patients will have a response to the prep, meaning they're going to start having bowel movements within about 2 to 3 hours of starting to drink the prep. Although this varies really widely, some people respond very quickly. Some people will drink the entire first half of the prep and have nothing that entire night in terms of bowel movements. And in those cases, I just tell them, sit tight, it's going to work. Just kind of be patient, and it will take its effect. It's very rare for it not to work, and in that case, we'll tell the patient to call us in the morning if they drank the entire thing and they still had no bowel movements. What should they expect in terms of common side effects? The most common things that we hear from the patient are nausea, not usually to the degree of vomiting, but vomiting can certainly accompany that. There's a lot of bloating, and with the bloating can come pain or discomfort in the abdomen, and then diarrhea. Diarrhea is what we want to ultimately see. So that's the side effect that is the goal. But also keep in mind that we're asking these patients to wake up at 1 in the morning sometimes, and kind of get no sleep the night before. So there's a lot of irritability. They haven't had food in a while. There's fatigue. There's other kind of factors associated with this too. So I wanted to kind of shift gears and talk about some of the most common patient questions that we often get and things that we can provide to them in terms of general advice. So the first thing, probably the number one question that I get is there any way that I can make the prep solution taste any better? It is not good. And I tell that to patients, that this is not going to be their favorite thing, but it is tolerable. And there are some things that can make it a little bit better. One of the things that they could try is to try to mix the solution with a powdered flavor packet, things like Crystal Light or like a lemonade packet, or so some of those things where you can kind of add the flavoring to it. I would have them make sure to try to avoid anything with a red dye in it again, but that can often help, although sometimes patients just say it kind of masks the horribleness of they're actually drinking. Other things to try include sucking on hard candy in between their glasses of prep, rinsing their mouth out with water or using a mouthwash in between glasses. I forgot to put in here, but how we do this is generally to tell them to drink 1 8-ounce glass of this every 15 minutes until they're done with that half. So kind of give them goals to work through, and so they can try to rinse their mouth out or use a mouthwash. Often the taste does improve if they chill the solution before drinking it. So that means mixing it up ahead of time and putting it in the refrigerator. However, it's also important for some patients to know that it's not uncommon when they chill this stuff that they can get really bad shaking chills with it and kind of start almost looking like they're rigering with it. Drinking it through a straw may help divert the taste away from some of their taste buds. And then another thing I saw mentioned was to suck on Italian lemon ices in between sips of the prep solution. There are different strategies with that. Nothing really makes it taste great. It's always going to be awful, but these may help it kind of get it down a little bit. Other questions that I often get: I'm not having bowel movements yet. What do I do? Usually, as I said, my advice for this is be patient. It will work. If the patients have not had any bowel movements at all after they've completed both halves of their prep, then they should call our GI endoscopy unit to talk to us, because typically in that scenario, they're going to need more prep and we'll have to reschedule their procedure. But for most patients, it's just a matter of kind of being patient and letting these things work, and in the end, it works out just fine. I'm getting nauseous or vomiting. Typically, this is because they're drinking too quickly. And so my first piece of advice for this is to have patients stop drinking the solution, take a break for 30 to 45 minutes, which will allow that solution to leave their stomach and get further down into their bowel. And then when they're feeling a little bit better, start back up again and maybe go at a slower pace in that scenario. It may take them a little bit longer, but usually they can mitigate that nausea and vomiting pretty easily that way. However, there are some patients where this is just that method does not work. And so they may need to be pre-medicated with some antiemetic medications prior to starting. And I have them do something like Zofran or some other anti-nausea medicine before they start both halves. So they should kind of start with that medication, and that often helps relieve that symptoms quite a bit. Do I really have to get up at 3 a.m. to start the second half of my prep? Yes. While this can make for a very early morning, and we realize that, the most important thing is that these patients get a good quality exam. And so it does mean that they're going to have their sleep interrupted for their procedure. They will get a nice nap when we give them their medications for that procedure, so that will often make up for a little bit, but they do need to do this part of it. And then finally, do I have to drink at all? Yes. And patients often with especially patients with chronic diarrhea, want to know if they still have to do it all even though they have diarrhea, and the answer is still yes. They do have to drink it all. They do still need to drink it all, even if things look quote unquote good, because sometimes what can happen is that you can kind of see a clearing with the first half, and then there's like a second wave of stuff comes through, and so you can have the stool clear out, and then it kind of gets cloudy and gross again, and so that drinking all of it helps to kind of wash all of that stuff through, and not just the first wave of it through. So what does good look like? Well, good looks like, when I talk to patients, it should look, what's coming out of their bottom should look very much like urine, meaning they can see through the entire thing. What that equates to in terms of their colon is that all of the debris is washed away. Things look really clear. There's nothing really getting in the way at all. If things look cloudy, or they still look brown or kind of brownish debris-ish, like if they do on the bottom, then they need to keep working. Other questions that we get is, what should we be doing with our other medications? First off, let's talk about aspirin. They should be talking to the GI team about their blood thinner medicines in general. So any anticoagulant, any antiplatelet drug, we want to know about it, because we will have them hold those. However, that is not true for aspirin. Studies recently have shown that if we stop the aspirin a week ahead of time, which was what we used to do, then it put these patients at high risk for developing cardiovascular events, heart attacks, strokes, that type of thing. It therefore is safer for them to stay on the aspirin, even though it can cause increase their risk of bleeding, than it is for them to stop it for this procedure. But we do want to stop the other blood thinners, so we need to know about those so that we can talk about when is the appropriate time to stop those medications. We also want to know about patients on diabetes meds, any diabetes med, that means oral meds or injections, so that we can talk about what we do with those medications. Often if they're on orals, we'll have them hold those until, while they're on the clears and afterwards, and then restart it after the procedure. And if they're on insulin, we usually half it, but we'll go through all the specifics with them. Generally speaking, it's okay to take all their other medications during and after the prep is done. So, but we ask that the morning of, that they try to take it with only a sip of water if possible. And then the last question that we often get is, I'm diabetic, what do we do if the sugar gets low? And the short answer is to drink clear juice and get that sugar back up. But also it's important, as I mentioned above, talk with the GI team about what to do with the diabetes medicines. So then finally, I just wanted to end with some general tricks and tips about things that can help. One is planning. Patients need to know that they should plan ahead for this procedure, clear their schedule so that they're off the day of their procedure, and they may want to make sure that they have the day prior a little bit cleared as well. They are going to need to make arrangements to do the prep someplace, whether that's at home or if they need to make special access to arrange for privacy during that prep. That is important. As I mentioned, drinking through a straw can help reduce the taste of the solution. They should have a lot of other clear liquids on hand to keep their hydration up, and those are perfectly acceptable to keep doing during the prep itself. One of the most important things that they can do is following the instructions, including what to do with their diet, what exactly they need to do with the bowel prep itself, that they're following all the instructions closely about what to achieve really good results. They need to be near a bathroom, as I said. They should have something to entertain themselves. They're going to be on the toilet an awful lot for this to prep for this procedure. So that means bring some music, bring some books, bring something to entertain them so they're not super bored. Refrigerating the solution can help beforehand, although I do try to warn patients that this can cause shaking chills that way, but that's okay. Use good toilet paper, really soft toilet paper, or try to get some of the toilet paper wipes to reduce irritation. Things get really irritated during this, as you can imagine, and that can really make a big difference. And then in terms of managing some of the abdominal discomfort, things like warm compresses or kind of a heating pad on the belly, or doing low impact exercise can make a big difference in helping to relieve some of that discomfort that they may feel. And that's all for now. Any questions from anybody?
We do welcome you to use the chat, or you can take yourself off mute if you would like as well for any questions. Looks like we have a quiet group today.
Yeah, that's okay. If you think of anything, don't feel, contact Amy. She has my email address. I'm happy to help answer questions by email too, if that's easier.
That sounds great. So Dr. Freeman, thank you so very much for taking your time today. We really appreciate your expertise and your support of the program. We do have our evaluation, as always, and Elsa has put that into the chat.
Perfect. I do have one question here about the Miralax prep.
Oh, sure.
Because we do the Miralax prep, but they add magnesium citrate the next morning, which does help improve it. And you're correct, it does help improve it. Ultimately, though, we felt that it didn't improve it enough, and so we were still spending a lot longer time having to clean and wash the bowel wall, even with the magnesium citrate added in, and it just wasn't efficacious enough for us. In addition to that, magnesium citrate, really, you need to be very careful about comorbidities and avoiding it, particularly in patients with known renal disease. So you have to make sure to screen patients appropriately for that.
Wonderful, thank you. Is there anything else? I know sometimes it just takes a minute to type, but like she said, anything you can send my way, and I will make sure that we get in touch with Dr. Freeman to answer anything you might think of later on. And again, that eval is in the chat box, so please take a moment to get that completed. And we will get everything together and send out a follow-up in a little bit. Oh, we have a question from Lupe. Does holding heavy foods like meat help pre-prep?
Absolutely, and that's why we have to put patients on clear liquids. We don't want a lot of food going into the GI tract the day that we try to start washing it out. So we ask them to stop solid foods the day prior and just go on a clear liquid diet that day, because yeah, it absolutely can have a big impact on how well the quality is.
Okay, so what about even longer than just the day before? What is really appropriate for those heavy foods?
Yeah, typically for that, that is not necessary for most patients. As I mentioned, there are certain patients, diabetics may be one of them because they're more prone to having constipation at baseline, patients on chronic narcotics, patients that have had bad preps in the past, that we may ask them to hold it for a longer period of time. But in general, we try to avoid it with most patients because holding it longer for most patients is not going to make a big difference in their ultimate bowel prep, except if they have really bad underlying constipation or kind of a tendency to slow colonic transit.
All right, wonderful. I don't see any more coming in.
Well, great. As I said, if you think of anything, I'm happy to help answer questions. Just shoot them my way, and I will help answer them offline.
Okay. Well, thank you, Dr. Freeman. We really appreciate it, and we hope that everyone has a wonderful rest of your day.
All right. Thank you, Amy.
Thanks. Take care, everyone.